Endo-Perio lesions. Periodontium and pulpal spaces represent two primary sites of dental infection from oral bacteria. Compound endoalveolar infection, involving both pulpal spaces and periodontal spaces, are common and present challenges for diagnosis and treatment. Persistent infection in the pulp tissue leads to secondary infection and breakdown of the tissues in the periodontium. Conversely, severe periodontal disease may also initiate or exacerbate inflammatory changes in the pulp. This mutuality of infection between pulp and periodontium is mediated through various routes of communication between these two spaces. So there are certain pathways for communication between endodontic and periodontal tissues. This involves anatomic pathway, pathologic pathway, and iatrogenic pathway. Anatomic pathways involves apical foramina, patent dentinal tubules, lateral and accessory canals, and developmental grooves, whereas pathologic involves external and internal resorption. And iatrogenic involves the perforations, over instrumentations, and vertical root fracture. So these are the pathways of communication. These being apical foramina, dentinal tubules, lateral or accessory canals, and the developmental grooves. And the other pathways are perforations, external resorption, overfilling during root canal treatment, as well as internal resorption. Now coming to definition of endoperio lesions. So what is endoperio lesion? It is a compound endoalveolar infection involving both periodontium and pulpal spaces of a single tooth. And we have other two terms also, which is retrograde periodontitis and orthograde periodontitis. So retrograde periodontitis is a advanced pulpitis leading to pulpal necrosis, which is often accompanied by inflammatory bone resorption at the root apex and leads to periodontal tissue breakdown from an apical to cervical direction. So retrograde periodontitis is the periodontitis happening from apical to cervical direction, whereas orthograde periodontitis is resulting from a sulcular infection extending from cervical to apical direction. So this is the retrograde periodontitis, which is occurring from an apex towards the crest, whereas on orthograde periodontitis, it is a sulcular infection extending from crest to the apex. Now, what are the factors initiating pulpal and apical disease? Pulpal and apical diseases are initiated by numerous external factors like microorganism, trauma, excessive heat to the teeth, restorative procedures, restorative agents, and malocclusion. These insults lead to inflammatory changes in the pulp, starting from reversible or irreversible pulpitis and ultimately progressing to pulpal necrosis and subsequent breakdown of the periodontium. Among this, dental caries is the prominent cause of pulpal disease, and bacterial infection is the primary form of microbial insult to the pulp. And as long as the pulp remains vital, it is unlikely that significant changes occur in the periodontium. Necrosis of the pulp can result in bone resorption and production of radiolucency at the apex of the root or in the furcation. The resulting lesion may be acute apical lesions or a chronic periradicular lesion or lesion associated with the lateral canals. And lateral canals are not usually visible on the X-rays. It is identified only when the root and lateral canals has been filled with a radiopaque material during endodontic therapy, and it is most commonly seen in the posterior teeth. And now, what is the effect of periodontium on the dental pulp or periodontitis on the dental pulp? Bacterial and inflammatory products of the periodontitis can gain access to the pulp through either accessory canal or apical foramina or through dentinal tubules. And severe breakdown of the pulp apparently does not occur until periodontitis has reached a terminal state, that it is when bacterial plaque has involved the apical foramina. And pulp also has got a good capacity for defense, and as long as the blood supply is maintained. And dentinal thickness also contribute to the protection of the pulp. Stanley et al. Stated that if a 2 mm thickness remain of the dentin between pulp and the irritating stimulus, there is little chance of pulp damage exist. So we have to take some precautions during the course of periodontal therapy. That is, first one, we should avoid using chemicals on the root surface. We should minimize the use of ultrasonic scalers when less than 2 mm of dentin thickness remains, and we should allow minor pulpal irritation to subside before completing the additional procedures. When these precautions are not followed, or the microvasculature of the pulp is damaged during periodontal procedures like deep curettage or periodontal surgeries, it can lead to necrosis of the pulp. Now, differentiation between pulpal and periodontal lesions. So what are the signs and symptoms of periodontitis? So it will be always free of acute symptoms. Bleeding on brushing can be seen, or flossing, or we can see bad breath, and there will be increased tooth mobility. The pocket may be tender to probing, and extensive deposit may be present on the root of the teeth. And probing is usually accompanied by bleeding in the deeper pocket with separation. Now, signs of pulpal disease. There will be pain, sensitivity to hot or cold food, tender to pressure, biting, light tapping with an instrument. Necrosis of the pulp can result in bony resorption, and there will be radiolucency of the apex of the tooth or in the furcation. So these are the different characteristics of pulpal and periodontal lesions in case of primary pulpal disease, primary periodontal disease, independent endodontic periodontal disease, and combined endodontic periodontic lesions. Now coming to classification of endoperio lesions. There are mainly two classifications by Simon and Gullner and Langerhans. Simon's classification. Based on etiology, diagnosis, prognosis, and treatment, it is classified into primary endodontic lesion, primary periodontal lesion, primary endodontic with secondary periodontal lesion, primary periodontal with secondary endodontic lesion, and true combined lesion. So these are the examples. This is primary endodontic lesion. We have primary periodontal lesion, secondary perio lesion, secondary endo lesion, and there will be combined endoperio lesion. Next is Gullner and Langerhans classification. It is based on the pathology. It is divided into primary pulpal lesion, primary periodontal lesion, and true combined lesion. Now coming to treatment consideration. Treatment is mainly based on the diagnosis. So we have a flow chart. What is the treatment planning of primary endodontic lesion? So in this case, we should go for endodontic treatment first and then reevaluation. And in case of primary periodontal lesion, we should initiate periodontal treatment followed by reevaluation. In case of primary endo lesion with secondary periodontal involvement, and if it is due to iatrogenic factor or fracture, we should seal the exposure. Root fracture management can be done. And after that, we should start with the endo lesion, then perio treatment should be completed, followed by reevaluation. In case of primary perio lesion and secondary endo lesion, we should start with the endodontic therapy and start perio after the endodontic therapy, and we should give time for reevaluation. And in case of true combined lesion, we should start with the endodontic lesion followed by periodontal treatment after completion of endodontic treatment and also reevaluate. Now, what could be done during a reevaluation period? If there is no resolution of the apical lesion and if it is hopeless prognosis, we can indicate the tooth for extraction. And in other cases, we can go for hemisection, root resection, and bicuspidization, which should be reevaluated after 3 months, or we can go for apicectomy. And if there is periapical resolution, we can retain the teeth. And if there is any mobility which is greater than grade 2 or equal to grade 2, we can go for splinting and followed by reevaluation after 3 months. Now coming to conclusion. The main route of communication between pulpal and periodontium is through apical foramina, lateral or accessory canals, and through dentinal tubules. A narrow probing defect combined with a non-vital pulpal response indicates that the problem is usually of endodontic origin rather than periodontal. And when endodontic therapy is the main cause of swelling or breakdown of the periodontium, successful endodontic treatment usually results in the healing of both the apical and periodontal tissue. And teeth with periodontal infection usually test vital to thermal testing unless the acute condition is a combined lesion in which both endodontic and periodontal compartments have been diseased. Teeth with both endodontic infections and periodontal abscess usually test non-vital, and combined endodontic periodontic lesions are best treated by performing the necessary endodontic treatment followed by periodontal therapy. Thank you.